We are going to discuss AIIMS May 2017 Dermatology questions. This is Dr. Shivam. Jai Hind and good day to all of you out here. A clear vision backed by definite plans gives you a tremendous feeling of confidence and personal power. You know, I have always believed that to clear this exam, you should have a clear vision and simple plan. You should concise your whole big syllabus into a small part so as to revise it easily and clear this exam with flying colors. Okay, you should set goals which are never easy, which should not be easy. They should force you to work even in worst of your situations. So we'll be starting with the question which AIIMS has asked you. A 30-year-old lady coming to you with 2 months history of non-scarring patchy alopecia on the left side. There was no erythema. Diagnosis is. Now, what all we should see? They are talking about patchy hair loss. Okay, non-scarring patchy hair loss. Other thing which we can see is there is no erythema. Now, patchy hair loss will be seen in alopecia areata and trichotillomania. These two options C and D have diffuse hair loss and not patchy hair loss. Now, among alopecia areata and trichotillomania, the alopecia areata will have smooth surfaced patchy loss and not incomplete loss, while we will see incomplete loss in trichotillomania. Okay, so here we can see this is not a smooth hair loss. Okay, this is something called incomplete hair loss in patch, and this belongs to trichotillomania. Okay, so they have pulled their own hairs and sort of psychiatrical condition. Okay, in a 12-year-old child, 4 hypopigmented patch on the back on the back and 4 on the forearm with loss of sensation. Treatment regime would be. Now, to answer this, you should know whether it is a case of paucibacillary or multibacillary. For paucibacillary, 1 to 5 lesion, no nerve or only one nerve, and negative all the sites for skin smear. Multibacillary, 6 or more lesions, more than one nerve, and positive at any site. So now you know that this child has 8 lesions belonging going more towards the multibacillary. Now another thing is this is child and not adult. Okay, so treatment here would be different for him. For children, rifampicin is 450 once a month, clofazimine is 150 once a month, 50 mg alternate day, dapsone is 50 mg daily, and for the total duration of 12 months. You should also know the adult dose, keep a screenshot. These are something which are asked in every exam, right from the NEET PG to AIIMS to PGI to any other exam related to your post graduation. Okay, so answer here becomes rifampicin 450, clofazimine 150, daily dapsone 50 mg, and clofazimine 50 alternate day. Very easy, but you should know them. Everything about leprosy is important for you. Ridley-Joplin classification and WHO classification. Now moving to this child which has a hyperpigmented patch with hair on the cheek since birth. The diagnosis is since birth. So already we are getting a clue of congenital melanocytic nevus. Okay, congenital part. Now why not verrucous epidermal nevus? Because there is no varicosity on the lesion, neither it is on the Blaschko line. So it cannot be verrucous epidermal nevus. Now I will tell you something about melanoacanthoma. Okay, the last option. These are very rare variant of seborrheic keratitis presenting as deeply pigmented proliferation of melanocyte and keratinocytes over the head, neck and trunk, and that too of elderly people, not child. Okay, so answer here becomes clearly congenital melanocytic nevus. So my main focus is to make you understand everything so that you don't need to revise it again. A patient comes with a skin and oral lesion, all are true except. Okay, so probably this is a question of mucocutaneous variety of pemphigus vulgaris. Now regarding pemphigus vulgaris, you should know that the antibodies are directed against desmosomes and not hemidesmosome. Okay, so only this point will fetch you the answer here. Okay, so antibody against hemidesmosomes are seen in bullous pemphigoid and not in the pemphigus vulgaris. Other thing which you should know is that mucocutaneous pemphigus vulgaris has both DSG3 and DSG1 antibody, IgG type. Okay, so this solves your question. A patient here comes to you with exudative lesion on his cubital fossa, popliteal fossa and neck. The diagnosis is it is very clear a case of atopic dermatitis, where you see typically in antecubital fossa and flexures like popliteal fossa in adults. Okay, exudation like oozing is a sign of eczema due to spongiosis seen in atopic dermatitis. Why not psoriasis? Because these occur classically on the extensors. Okay, so psoriasis it cannot be. Atopic dermatitis, yes. Although we get a variant of psoriasis called flexural psoriasis, but they do not ooze. Why not dermatitis herpetiformis? Because they will have itchy excoriation and something related to hypersensitivity of gluten will be found. AIIMS are asking that a child comes with a circular 3x3 scaly patchy hair loss with itching in the lesion. Investigation of choice is, so pick up the terms: scaly, itchy, localized patchy hair loss in child, probably a tinea capitis. Thus the answer becomes KOH smear, which is done from the loose hairs. Split skin smear is for leprosy and leishmania. Zinc smear is for herpes and pemphigus. Okay, now moving to this picture which comes in every alternate year, maybe in AIIMS, PGI and NEET PG, but it is going to be there. So patient comes with genital ulcer, his biopsy is given, the diagnosis is clearly Klebsiella granulomatosis. It shows an intracellular organism Donovan bodies, and if you see in high power it will show you closed safety pin organism. So clearly Klebsiella granulomatis and a case of granuloma inguinale. Now antibiotic acting against the leprosy organism is, so ofloxacin is the answer because it is a second line drug for the leprosy. None other options are the for leprosy. Okay, so answer becomes ofloxacin. Now if I ask you what are other second line drugs for the leprosy, it can be clarithromycin and the minocycline. Moving to the other very common picture, histopathology is given. You have to fetch the diagnosis. The diagnosis is suprabrachal split with row of tombstone, a case of pemphigus vulgaris. Okay, so these pemphigus bullets are something which will be asked from the dermatology section. Have your concept crystal clear in them. Everything you should know about them. All are caused by staphylococcal toxin except toxic shock syndrome, yes. Scaldal skill syndrome, yes. Food poisoning, yes. Septic shock, no. A female comes with frothy green vaginal discharge of 5 days duration. There was a strawberry cervix on examination. The drug of choice is clearly metronidazole. Green frothy vaginal discharge with strawberry cervix suggests you a diagnosis of trichomonal vaginitis, and the metronidazole is the drug of choice. Now for after seeing the abundance of request and demand for guidance, I have made a one-to-one platform where we can talk and discuss your problems, and probably will lead to something better for you for your exam preparation, and we'll see what I can do for you. And as I am giving my effort, will ask from you, will demand from you your 100% for your purpose, for achieving your dreams, because only you can do something for achieving your dreams. Dreams belongs to you, so the hard work should come from you. This is Dr. Shivam signing off. Stay happy, stay motivated, stay cool, and do whatever you want to do. Thank you.